mornings, if you will. Our next talk is going to be by Dr. Ann Augustine. Dr. Augustine is an assistant professor in the Department of Neurology at Duke University Medical Center. She is also a member of the Neurodiagnostic Center at the Veterans Affairs Medical Center in Durham, North Carolina, and she's a medical director of the sleep laboratory at the Durham VA. And Dr. Augustine will be talking about hypersomnia. Thank you, Dr. Augustine.
Thank you. So I have no disclosures, and I'm going to start off with a case, which is sort of representative of many patients who come to our clinic. So Megan is a 28-year-old woman who was referred for evaluation of excessive daytime sleepiness, and she's been experiencing this for years, as far back as her adolescence. And no matter how much sleep she gets, she never feels fully refreshed. And when you talk to her, she tells you that she goes to bed at 11 p.m. to midnight, and she's usually pretty sleepy around then, and she can fall asleep within minutes. Sometimes she wakes up about 3 times per night. It can be a spontaneous awakening, and sometimes she might have trouble falling asleep. Her alarm goes off at 7. She's still a little tired around that time and might hit the snooze a few times, and really only gets out of bed around 7:30 to 8 a.m. She doesn't take any stimulants or sleep medications. She doesn't report any snoring, gasping. No one's ever said that she stops breathing in her sleep. She uses an average amount of caffeine, about 1 cup of coffee in the morning, sometimes might have a soda with lunch, and drinks only occasionally, a social drink with friends, and denies any use of tobacco or any recreational drug use, and she teaches the 3rd grade. So in terms of her past medical history, fairly benign. She has a history of depression that she treats with escitalopram. Otherwise doesn't report any other issues. And on her exam, she's not obese. She is awake, alert, conversant. Her vital signs are normal. And there's no focal deficit seen on her cardiac or pulmonary exam. Her neurological exam is normal as well. And when you look at her oropharynx, you don't see a lot of crowding by her tongue or any excess tissue behind the tongue. And she's got a small neck size. And you ask her to fill out an Epworth sleepiness scale. The scale basically looks at the degree of sleepiness patients have during sedentary activities, 3 being the highest they can rate for each activity. And she scores a total of 18 out of a total of 24 points, indicating a high degree of sleepiness. So what exactly is hypersomnia or excessive daytime sleepiness? Basically, it's the inability to stay awake during the day. Oftentimes, patients report an irresistible urge to have to sleep or may unintentionally fall asleep. And you want to make a distinction between that and fatigue. Fatigue is often an exhaustion people report where they have sort of feel drained of physical or mental energy. These patients may not necessarily report sleepiness when you ask them straight out, but they just don't feel that energy to get off the couch kind of thing. And it's a pretty common problem. In one study, about 12% of referrals over a 22-month period were for hypersomnia. And a poll that was conducted in 2008 showed that about 18% of respondents reported having at least a mild degree of sleepiness with an Epworth sleepiness scale greater than 10. And population studies have also shown a prevalence of daytime sleepiness anywhere from 9 to 26%. So we care about excessive daytime sleepiness, and it's because of the consequences that can occur. There can be motor vehicular accidents, occupational accidents. Patients who report a lot of sleepiness can find that their home life or relationships are not working out well because they can't be present and engaged for them. And patients will also report having trouble at school. They're not able to tune in and be focused, and same at work as well too. So you always want to do a thorough evaluation, and part of that really comes down to taking a really good history. So you want to figure out how much sleep do you estimate that this patient is really getting. You want to know what time they go to bed. Are there any delays to falling asleep? Oftentimes distractions like being on your iPad, watching TV can prevent sleep. You also want to find out if they're waking up during the night and why are they waking up? Are they waking up because of anxiety? Are they waking up because of pain or nocturia? And you want to find out what time they're also getting up. You want to know if they're falling asleep during the day, whether it's unintentionally or if these are planned naps. And how much caffeine, alcohol, tobacco, substances in general are they using, because those can disrupt sleep. And ultimately how much people exercise too and what time they're exercising, because late night exercise can also be disruptive to sleep as well. You also want to review your medical history as well. A lot of our medical disorders can also result in fatigue or sleepiness. And so you want to check their cardiac and pulmonary history. Patients with neurological disorders such as Parkinson's disease may also report a lot of sleepiness. It's not uncommon for patients with autoimmune disorders, say such as multiple sclerosis or other autoimmune disorders, including fibromyalgia, may report fatigue. Depression and anxiety are also very closely linked to having difficulties with sleep, poor sleep quality, and experiencing sleepiness during the day. And a lot of medications that we commonly prescribe, such as antidepressants, even beta blockers, pain medication, can result in sleepiness as well. And oftentimes we prescribe sleep medications for patients who say that they can sleep, but as a consequence, they can also feel like they're unrefreshed during the day, especially if it's not being metabolized well or if they're taking high doses with other medications as well. So on the exam, you want to look for factors that might suggest that patients might have sleep apnea. So as mentioned before, you want to look at tongue and tonsil size. If you're seeing a lot of crowding behind the tongue, do they have a small chin that's displaced posteriorly, retronappia? And if they have a large neck circumference, all these things can point to signs of sleep apnea. You also want to do a cardiac and pulmonary exam because, again, if you find signs of atrial fibrillation, congestive heart failure, wheezing suggesting COPD, these comorbidities often be seen with sleep disordered breathing, or of themselves also contribute to daytime sleepiness. Neurological exam, like I mentioned, you want to rule out things like whether patients have neuromuscular disorders or movement disorders. That could signify that patients might have some of these daytime sleepiness or fatigue. And sometimes you need to do some testing for hypothyroidism or diabetes because these two can all contribute to a feeling of lethargy during the day. So this slide shows you a differential diagnosis of reasons for why patients feel sleepy during the day. I think one of the most common reasons is insufficient sleep, and that's why you want to take a really sleep history. A lot of times you might ask a patient, well, if you're able to get a couple of hours more of sleep, or if you're able to sleep in on the weekends, do you feel refreshed? And often that answer is very telling. Patients will, if they say that they actually do feel better after extra sleep, indicate that they're not getting enough sleep at night. You also want to rule out other sleep disorders, as I mentioned earlier, obstructive sleep apnea, restless leg syndrome, limb movements. All of these can be very disruptive to sleep. And those are things that you want to address independently. Circadian rhythm disorders also can contribute to daytime sleepiness. For example, delayed sleep phase disorder. These patients are the night owls. They like to sleep very late versus conventional times when patients go to bed, and also they also will wind up waking up much later in the morning. And for them, if they have to fit their sleep schedule into, say, a traditional work schedule, having to wake up in the morning, they can be shortchanged on sleep and arrive to work feeling very sleepy. So that's something that you need to look out for also. And patients with shift work sleep disorder, if they're having, working the third shift between 11 p.m. to 7 a.m. and having to change shifts on a rotating basis, this can also contribute to poor quality sleep, feeling unrefreshed during the day. Again, you want to rule out the use of sedating medications and other medical disorders, including depression. And narcolepsy and idiopathic hypersomnia are the two topics that I'm going to focus most of this talk on. So getting back to Megan, you discover she's a healthy young woman. Depression is well managed. She's getting an adequate amount of sleep. She's not taking any sedating medications, and she doesn't fit the profile of someone who has sleep apnea. She's not obese. She's premenopausal. and she doesn't report any snoring or gasping in her sleep. But when you probe a little further, you find that she has this irresistible urge to fall asleep during the day, affecting her ability to stay awake at work. And on a few occasions, she's woken up spontaneously from sleep and found that she's sort of locked in place where she can't move a muscle. And she doesn't experience any vivid dreams or, getting the sense that something else is in the room when she wakes up out of sleep or on falling asleep. But she does note that, on occasion in the past, when she's told a joke and starts laughing, her knees will buckle, although she hasn't really experienced this for the last couple of years. So in your differential, you're probably thinking that maybe she has narcolepsy. And narcolepsy is a disorder that affects 1 in 2,000 people. It affects men and women equally. Oftentimes symptoms can actually start in childhood up to early adulthood, but it can take about 5 to 15 years to get a diagnosis. So sometimes there can be a pretty prolonged delay in getting a diagnosis. And there are 2 types of narcolepsy. There's type 1 and type 2. Type 1 is associated with cataplexy versus type 2 is without. So why does it happen? Well, what we know about narcolepsy is, at least with type 1 with cataplexy, that there's a loss of hypocretin that's seen. And these neurons are located in the lateral hypothalamus, and they no longer start producing the hypocretin. With type 2, we're not exactly sure why that's happening. The pathophysiology is unknown. It could be multifactorial. And when we test the patients for hypocretin, some have low hypocretin levels, but some can also have normal levels. A genetic locus called HLA-DQB1602 has been implicated as a possible factor. More than 90% of patients with type 1 narcolepsy will carry this gene. In patients with type 2, it's approximately 50%. However, we know that in the general population, about 12 to 30% carry this gene. So it's not specific to narcolepsy, but carrying this gene can actually increase your risk 200-fold of having narcolepsy. So REM sleep, so narcolepsy is a disorder of REM sleep and regulation. So, what we know about REM sleep, it's associated with rapid eye movements. There is also a loss of muscle tone, we call muscle atonia, with the exception of your eye movement muscles and your diaphragm muscles that assist with breathing. And patients, during REM sleep, this is when we have, that vivid dreaming that we experience. So in patients with narcolepsy, REM sleep actually can occur any time of the day. There's like an intrusion of REM sleep during the daytime. And it's not just confined to just the normal sleep cycle. So narcolepsy is associated with a tetrad of symptoms. So there's the excessive daytime sleepiness. In patients with type 1, they experience the cataplexy. There's sleep paralysis and sleep hallucinations. Now, when patients present for evaluation, they don't always come with all 4 symptoms at once. Only 10 to 15% of patients will have all 4 symptoms on presentation. And daytime sleepiness is one of the first symptoms to present. Typically, it's an acute onset, but it can be gradual. And patients report feeling sleepy despite getting adequate sleep. Patients with narcolepsy will often feel refreshed initially after awakening, or they can feel refreshed even after taking a nap. But this feeling of alertness is often just very short-lived. It doesn't really take care of their sleepiness problem for the day. Cataplexy is a loss of muscle tone triggered by emotion, and that's the key part. So oftentimes, you might hear from a patient that they're told a joke and they start laughing and their knees might buckle or they feel some weakness. Oftentimes it's a positive emotion, although negative emotions like sadness or anger could potentially do that as well too. The paralysis feeling lasts for seconds to a couple of minutes. And oftentimes, patients sort of relate cataplexy to some of the more dramatic YouTube videos that you see where people fall over. And that's not always the case. And I think that's why sometimes cataplexy can be missed. It can be a subtle weakness where people might lose some grip from their hands. They might feel that their face sags. They might feel, their neck go weak and drop their head. They might feel a little buckling around the knees. But sometimes it can evolve into losing muscle tone throughout and can result in falling over. Sleep paralysis is another characteristic of narcolepsy. Basically, patients might experience a loss of muscle tone, sort of a paralysis, really on awakening or falling asleep. And this can be kind of a frightening experience because they're not moving. And it can also be accompanied by sleep hallucinations. These symptoms, though, are not exclusive to narcolepsy. About 20% of the general population will report experiencing one of these. And I like this picture over here because I think this gives you a really, it's like a really nice visual representation of what sleep hallucinations and sleep paralysis is. And a lot of times when we ask patients about sleep hallucinations, we ask them, if, do you have really vivid dreams? And I sometimes feel like that's probably not the best way of asking it, but I like the term vivid perceptual experiences. And these are usually visual and there's like frightening content. And patients really truly feel like there's something or someone present in the room with them, but that's not actually there. And we describe sleep hallucinations being hypnagogic when patients fall asleep and hypnopompic that they experience it on awakening. Patients with narcolepsy will also report having fragmented sleep because, again, there's actually this intrusion of wakefulness during their sleep at night, during nocturnal sleep. In children, they can experience a 20 to 40 pound weight gain. And having narcolepsy doesn't mean that you're immune from having other sleep disorders as well, too. So patients can also have concomitant obstructive sleep apnea, restless periodic limb movements, or even REM behavior disorder. And oftentimes depression is present. So I like this diagram here because it kind of gives you a representation of patient overnight sleep with narcolepsy. And what you see here during REM sleep is actually seen earlier in the night. It's actually in this hypnogram, it's happening on sleep onset. And technically, REM sleep should really be happening about an hour and a half after sleep onset. The other thing that you're seeing here is the fragmented sleep or sleep disruption that's associated with narcolepsy. And you can contrast this to a textbook sleep hypnogram where REM sleep is happening after those 90 minutes after sleep onset. And you have fairly well consolidated sleep with lengthening cycles of REM sleep during the second half of the night. So we go about diagnosing narcolepsy. So we do this with a multiple sleep latency test. And basically, we ask patients to do 4 to 5 naps during the daytime. Each nap is 20 minutes each, and they're conducted at 2-hour intervals. And basically what we're looking for is how fast does a patient fall asleep during this nap? And then we average that time over the 4 to 5 naps, what we call the mean sleep latency. The other thing we're looking for during these naps is, does REM sleep appear? Because again, REM sleep is supposed to occur 90 minutes after sleep onset. So if it's occurring during a 20-minute nap, that's abnormal and can be suggestive of narcolepsy. So to get that diagnosis, you're looking to see a mean sleep latency of less than or equal to 8 minutes, indicating a high degree of sleepiness. And you're also looking for more than 2 or more sleep onset REM periods. The only issue with the MSLT is that it can sometimes have a high false positive and a high false negative rate because there can be confounding factors, whether a patient has been getting adequate sleep prior to coming for the study, whether medications were involved. So those things can also affect this outcome of the study. And sometimes you just may not capture it on that particular day for the study. Whenever you run an MSLT, though, you always want to do an overnight sleep study, a polysomnogram the night before. And the reason you do this is that you want to rule out other sleep disorders such as sleep apnea. If that's present, then you don't continue on to the multiple sleep latency test. You have to manage that issue first. The other thing that you're looking for is to make sure the patient got at least a minimum of 6 hours of sleep. The concern is that having less may mean that a patient might look like they have narcolepsy, but it's really not due to narcolepsy, but probably due to insufficient sleep. Ideally, you also want to get a 2-week sleep diary with or without actigraphy. Basically, you're trying to make sure that there is a consistent pattern of getting adequate sleep over time. And the other thing that you instruct patients is that 2 weeks prior to the study, you ask them to, If they can, avoid any hypnotic medications, any sleep medications. You want them to stop any stimulants or any antidepressants because those are REM suppressing meds and can alter the findings of the study. So what about hypocretin testing? That would seem like the most obvious thing to go to. However, hypocretin testing is invasive, it requires obtaining CSF. And sometimes, it is done. And what you're looking for is an absence of hypocretin 1 in the CSF. But there are limitations by insurance. Typically, insurance will not pay for the study. And until recently, I think it was not really even commercially available. Though recently, I think I saw on Mayo's lab ordering website that they do offer it. So let's just say that you have a patient with excessive daytime sleepiness, you run the MSLT, and you show that there is a lot of sleepiness with a mean sleep latency less than 8 minutes, but you're not capturing those sleep onset REM periods. Oftentimes that patient will receive a diagnosis of idiopathic hypersomnia, especially if they're reporting that they're getting more than 11 hours of sleep and they're still not feeling refreshed. Oftentimes these patients will report that they're taking long naps and still not feeling better afterwards. They may report sleep drunkenness. And when tested, actually their hypocretin levels are typically normal. Idiopathic hypersomnia is also very similar to narcolepsy in the sense that patients will report symptoms in adolescence or early 20s. And it's problematic because a lot of times these patients will come in saying that they can't function at work or school. They're having trouble staying focused and being able to complete their tasks. And about 14% of these patients, their symptoms may just remit on their own. But most of the focus on for these patients is really just treatment of the sleepiness. And for these patients, the treatment really revolves around, for narcolepsy patients, is about maintaining wakefulness, treating cataplexy if it's present, consolidating sleep if they're reporting fragmented sleep, and also addressing other sleep disorders. So this table here shows some of the commonly used medications that we use in treating narcolepsy. Oftentimes we go to medications such as modafinil or armodafinil. These are non-amphetamine type stimulants. And the reason we go to these first is because they have a pretty fairly benign side effect profile. For patients where it works, it can work pretty well. You do have to warn patients that there can be a risk of Stevens-Johnson syndrome, and for patients who are on oral contraceptive, it can lower the efficacy of that. But again, that doesn't work for everyone. Sometimes you have to go to more traditional stimulants such as methylphenidate, dexedrine, or Adderall. And for these medications, they can be effective, but you always have to monitor carefully, particularly blood pressure and heart rate, to make sure those are not getting elevated. And then you also have to monitor because there's always the potential risk for abuse with these medications. Sodium oxybate is also used in narcoleptics who report excessive daytime sleepiness. The advantage of this is that it can help consolidate sleep. It's also a controlled substance, and patients have very specific instructions on how to take it. They're instructed to actually take it twice a night, first on going to bed, and then to set an alarm a few hours later to take the second dose to help consolidate their sleep. And this can be pretty effective. And it's actually also used in treating cataplexy as well. So it has two indications, for daytime sleepiness and for treatment of cataplexy. But there are also other medications that are available that we use for cataplexy, primarily medications that suppress REM sleep. And that includes venlafaxine and SSRIs, such as fluoxetine. Clomipramine can be used as well. Another thing that you want to focus on with these patients is also addressing their behavior. So you also want to make sure these patients are engaging in good sleep habits. Telling narcoleptic, we'll try to get a little extra time in sleep may not be very helpful because their sleep is often very fragmented. In some cases, if it's possible, if it's something that they can fit into their routine or schedule, having them sort of have a short nap, a 15-minute, 20-minute nap, or if they have the possibility of up to 2 hours, can sometimes help improve their alertness over a few hours and maybe cut down on their use of needing medication. And as with all patients, you always want to warn patients as well about driving and sleepiness. For anyone who has narcolepsy or sleepiness due to any other concerns, at least here in North Carolina, physicians do not have to report. And this can vary from state to state, whether physicians have to report or not. Patients, I think, patients who are looking for a driver's license typically have to report whether they have a sleep disorder, and that's voluntarily reported. And if they do report that, oftentimes they might need to submit a medical evaluation or a statement that their condition is pretty well controlled. So let's get back to Megan. So we did a study on her with a 2-week actigraphy. We asked her to stop her escitalopram for 2 weeks. What we found is that she's actually getting, she was a pretty good reporter. She was getting to bed at a consistent time, getting adequate sleep. And on the polysomnogram, we didn't see any sleep apnea. She was getting 7.5 hours of sleep, but she did sleep within 6 minutes. And her REM onset actually came early at about 60 minutes. And her sleep appeared kind of moderately fragmented. On her MSLT, she showed a mean sleep latency of about 5 minutes. She showed 3 sleep onset REM periods. And also with the testing, we also do urine tox screen to make sure that there are no other substances that alter the results. For Megan, we treated her with modafinil, and we went up on the dose. This didn't really work for her. And so we switched over to our modafinil, and that actually did improve her symptoms, and she was able to function well at work. And for her cataplexy, it hasn't really been an issue for her for the past 2 years, and this might be because she had been taking the escitalopram during this time, which is a REM suppressing drug. And so that concludes my talk.
Thank you so much, Dr. Augustine, for that talk. We appreciate your time today. We have a number of questions. I'm going to let Dr. Hussain kick it off with the first question.
Perfect. Thank you, Victoria. So, Dr. Augustine, excellent talk. First question is a practitioner who works at the VA and sees a high percentage of veterans with obstructive sleep apnea, in addition to insomnia and PTSD or PTSD. Is there a correlation in your experience, not directly related to the hypersomnia, but given your background at the VA, perhaps you want to address that?
So you're saying obstructive sleep apnea, insomnia, and PTSD?
Correct.
Yeah, I think, experience with these veterans, it's really complicated. And I think you sort of have to take each symptom and try to address them individually. And so you want to treat the sleep apnea if that's present. Sometimes I think that can be a really challenging thing for veterans because a lot of them have difficulty adhering to using CPAP. And you might want to look for other alternative methods of treatment of sleep apnea, such as using an oral appliance and encouraging weight loss for some of them if they're able to. And then also independently addressing their insomnia. I think a lot of times the insomnia and PTSD picture, and also if they're having like mood issues, anxiety disorders, this can also really play a role in how they're feeling sleepy during the day. So you can have someone who actually has their apnea pretty well addressed, but I think all these other issues between the insomnia and mood issues and the PTSD can contribute significantly to that daytime sleepiness. And I think it's really hard to get a hold of that. I think in some cases we do wind up treating with stimulants in that kind of case. In my personal experience with a lot of these patients, I don't know that the stimulants have been very effective. I mean, they still continue to report sleepiness, but right now, if you've addressed all the other factors, that's kind of all we have right now to give them and try to really do a good focus on getting enough sleep at night, because a lot of times they'll report insufficient sleep too.
Okay.
Next one. Do you have a specific way that you ask the question in order to uncover subtle cataplexy symptoms with your patients?
Yeah, I usually try to, ask about more subtle symptoms, and asking about it, I want them to tell me first. Like, I don't want to lead them on with a certain type of question. So I'll ask them, I'll sort of go off with a broad question, like, have you ever experienced any muscle weakness, in the context of an emotion? I'll just keep it broad like that. And depending on what their answer is, and I might probe a little further. Really, I'm just looking for them to tell me what they experience. And usually they might say, well, this is what happens when this occurs, whether it's, I wind up dropping something. One of my favorite anecdotes was I had a patient who told me that whenever he saw his daughter do something cute, his knees would buckle, and he gave the example of stealing a bite of brownie off of his toddler daughter's plate, and she had this surprised look on her face, which hit him as being cute, and then his knees buckled, and I thought that was like a very good example of it.
So I think we're at time. There's a couple of very interesting questions, very practical ones. Why don't you answer this? They're very practical, Dr. Christine. What do you do if you can't get people off of an antidepressant or a stimulant for 2 weeks in 30 seconds?
Oh, so that's actually a very common thing. And frankly, I will sometimes still run the study potentially, because you do see those 2 sleep onset REM periods in the setting of a REM suppressing drug. I mean, that to me still says that they probably have, there's a good chance that this person has narcolepsy. In some cases, if it's too dangerous, then we might just say, look, we are going to presume you have narcolepsy and try to find alternate treatment or try adjusting your medications and see if that helps.
Great. Thank you very much, Dr. Augustine. Greatly appreciate it. Again, we're going to have time at the end for additional Q&A. But we're going to move on to our next talk. The next 2 talks are going to be insomnia related. The first one is insomnia diagnosis and behavioral therapy. And for that, I'm delighted that Dr. Meg Danforth is going to join us. Dr. Danforth is a clinical associate in the Department of Psychiatry and Behavioral Sciences at Duke University. And Dr. Danforth is our primary go-to person when we have patients who have difficult to treat insomnia or otherwise need behavioral management of their sleep disorder. So thank you, Dr. Danforth. Look forward to hearing your talk.
Thank you, Dr. Hussain. I appreciate the invitation today. So what we have with insomnia is a condition that is broadly prevalent. Our guess is that in a tertiary care medical center setting like Duke, fully half the patients who walk through the door for any reason meet concurrent criteria for insomnia disorder. What we also have with insomnia are treatments that work. They are not hard to do. They can be done in as few as 2 visits, and they can be done by clinical psychologists or by other kinds of providers within a primary care setting. What we don't have are enough people out in the community who are aware that insomnia is something that's treatable. And so I never turn down the opportunity to evangelize about insomnia, and in particular to evangelize about CBTI, cognitive behavior therapy for insomnia. We don't have enough time this morning to actually teach you how to do CBTI. So what I'd like to do is give you an overview of what CBTI looks like, give you a sense of the kinds of things that are involved. And to do that, I want to walk you through a case of a patient that we treated actually since COVID. So this is one that we've done entirely over telehealth. So we're going to call this patient Dave. Dave is a relatively recent retiree, 66 years old, European-American man. He is married. He had a career in grocery wholesaling and retired about a year ago. And he is relatively healthy. In terms of past medical history, the significant issues are a history of osteoarthritis. He does have high blood pressure. He does have obstructive sleep apnea. It's of moderate severity, and Dave is a CPAP user. He actually was referred to us by Dr. Hussain's clinic to evaluate his insomnia problem. In terms of mental health history, Dave's psychiatric history is entirely unremarkable. Like many of our patients, he had never before consulted a psychologist about anything. And his primary sleep complaint is this. He says, I've had sleeping issues for 20 years. For most of our patients, they can identify some precipitating factors that might have initially contributed to sleep difficulty. In Dave's case, he thought that work stress played a big role, at least initially. And he was someone who had said to his wife, I can't wait until I retire so that my sleep problem goes away. But he found that after his retirement, sleep problems persisted. The other precipitating factor for him was several years ago, he did have a total knee replacement, and he had a significant amount of knee pain leading up to the surgery and then a prolonged recovery. And he did think that that had been a factor in contributing to frequent middle of the night awakenings, but that was not an issue at present. Like many insomnia patients, Dave had made a number of attempts to manage his sleep problem over the last 20 years. He reported a long stretch of time taking trazodone. It was prescribed by primary care. He couldn't remember why he had stopped taking it. He did find that it was somewhat helpful, but left him feeling really groggy. And right now, when he presented to us, he wasn't taking any sleep medicine at all. He, like many patients, had gotten a pretty thorough education in sleep hygiene recommendations. So things like avoiding alcohol, limiting caffeine, not exercising too close to bedtime, keeping his sleep environment pretty comfortable and cool and quiet. He did not find that any of those lifestyle changes had helped. He did pick up a pretty good habit of doing relaxation therapy and also doing meditation. So he was using some meditation apps for daytime practice. So what is chronic insomnia? When we're talking about insomnia, we could be talking about trouble falling asleep, trouble staying asleep, waking up earlier than you want and not being able to get back to sleep. Or in some cases, patients with insomnia may have a primary complaint of persistently non-restorative sleep. A really important thing to know about insomnia is that insomnia is a subjective disorder. So we're not trying to quantify how many nights a week is this happening? How many minutes objectively is it taking Dave to fall asleep? How many times does he wake up during the night and for how long? What we want to know is this: does sleep feel difficult to Dave? Is he having a hard time falling asleep? Is he awake more than he thinks he should be at night? Does he wake up earlier than he wants to in the morning? It's those subjective complaints that make up what we think of as being chronic insomnia. So we talk about insomnia as being a 24-hour disorder. And what we mean by that is it's not just the nighttime complaints. For a patient like Dave, there are usually a host of problems with daytime functioning. And for many of our patients, those daytime function complaints are even more salient than what's happening during the night. So what we hear from with patients like Dave is we hear fatigue, low energy. There's a sort of subjective experience that they can't do what they're being called on to do during the day. Often there are somatic complaints, headache, increased pain. There are mood symptoms like irritability. There are subjective cognitive complaints. So patients like Dave complain of memory difficulties, trouble concentrating, trouble initiating tasks. One of the things that's interesting is that those are subjective complaints. When we take patients with chronic insomnia and we put them through neurocognitive testing, generally we actually see that they're functioning within normal limits. So they're coping really well cognitively. There's just, again, this subjective experience that's really hard. For some of our patients, they actually function extraordinarily well during the day. What makes them have insomnia is that they're excessively worried or concerned about their sleep. And often that anxiety about sleep escalates as bedtime approaches. Finally, If we're talking about DSM-5 criteria for chronic insomnia, DSM-5 includes a durational component. DSM-5 says we're not going to call this chronic insomnia unless it persisted for at least 3 months or longer. And there's actually a really good reason for this diagnostic criterion. Virtually 100% of human beings will have the occasional insomnia night. That's just part of the business of being human. You've got a stressful test coming the next day, you've gotten bad news, you are, thinking about how you're going to manage with your kids in school during COVID-19. That kind of thing is not chronic insomnia. It's also really common for a patient to have a bout of poor sleep that's in response to a stressful life event. So it could be that you're not sleeping well because of a job loss. Or in the case of Dave, he occasionally slept poorly because of work stress. He had a stretch of poor sleep around his knee replacement surgery. The vast majority of those kinds of short-term acute episodes of insomnia are going to resolve on their own. You get another job, or you start drawing on insurance benefits and you can pay your bills. You rehab the knee and you're not having knee pain. You get accustomed to your divorce and sleeping alone and you go back to sleeping okay. Once insomnia persists for longer than about 3 months, it is extraordinarily unlikely to go away on its own. That's because sleep problems have a way of taking on a life of their own for reasons that we're going to talk about in just a little bit. So the patients that we're going to be treating with CBTI are the patients like Dave who say, I started sleeping poorly when I was experiencing a lot of work stress. Having chronic knee pain and recovering from knee surgery made worse, but right now I'm retired. I don't have a care in the world. My knee is relatively pain-free. Why am I still not sleeping? So in our assessment process for insomnia, we're going to be using a couple of clinical tools. The first is the one that's most familiar to us as providers, and it's also the most obvious. If you want to know if sleep is of concern to your patients, you have to ask them. And that means doing some kind of clinical interview. Having said that, there are some really significant limitations to our patients' retrospective recall about their sleep, which is a very diplomatic way of saying that in general, patients are terrible about describing their sleep in general terms. They'll say things like, oh, I get 6 hours a night, or I always go to bed at 10 and I get up for the day at 6. And they're not necessarily lying to you, but when they sort of retrospectively give you these global estimates, they're glossing over lots of day-to-day variability that's going to be important to us when we're treating insomnia. And so in addition to asking our patients retrospectively about their insomnia, it's really essential that we collect prospective information about our patients moving forward in time. The tool that we're going to be using for that is the humble paper and pencil sleep diary. For those of us who practice CBTI, the sleep diary is the essential tool. We're going to be using that to assess, is this actually chronic insomnia? We're going to be using it to identify what our clients might be doing that could be causing their sleep problem to persist over time. We're going to be using diaries to monitor adherence. So when we do CBTI, we ask patients to do things like set an alarm for 6 a.m. and at the same time every day. We don't know if our patients are doing that unless we actually have them get up in the morning and write down their get up time. Finally, we use sleep diaries to track the effectiveness of our treatment over time and to modify that treatment as we follow up with patients. There are many, many variations on sleep diaries that are floating around out there. I'm going to put in a plug for using a specific validated sleep diary, which is called the consensus sleep diary. There actually are 3 versions of this. The one that we most often use in my practice is called the Consensus Sleep Diary Core. It's 1 page of diary data that holds a whole week. There's a page of instructions. And when I hand these out in paper, I usually have double-sided copies so that the instructions are on the back of every page. The diary and the instructions are normed at a 3rd grade reading level. So they're meant to be accessible to most of the patients that we work with in our practice. At a minimum, in order to do CBTI, we need at least a week of diary data. And we want that diary data to be fairly representative of what's going on in their personal lives. So if they do a week of diaries, but then they tell you they were at the beach with their extended family, we may want to have them redo that. So let's take a look at a sleep diary for our patient, Dave. So this is a week of Dave's sleep diary at baseline. So this is week 0 before treatment. Day of the week goes across the top. And going down each column, here's the information Dave has given us about his sleep. What time did he attempt to fall asleep? About how long did it take him to fall asleep? How much time did he spend awake during the night? What time did he wake up for good? And what time did his feet actually hit the floor? Because often those are not the same thing. When you have a week of diary data in front of you, then you have the capacity to actually do some sleep diary math. And so when we have diaries, first thing that we like to do is go through each night and say, okay, how much time did this patient spend in the bed last night? What was their opportunity for sleep? And then of that, how much time did they actually spend asleep? That means subtracting out the time it took them to fall asleep, the time they spent awake during the night, and the time they spent lingering in bed in the morning, which in this case was on a number of occasions, several hours that they spent before they actually got out of bed. Last thing that you can calculate from a sleep diary is night by night, what was Dave's sleep efficiency? So sleep efficiency is the ratio of sleep to time in bed. And for good sleepers, we like to see sleep efficiencies of between 85 and 90%. For our seniors, and Dave was 66, so he is in that range. For our seniors, we expect a little bit more wakefulness during the night, so we're happy to see sleep efficiencies of about 80 to 85%. In this particular case, over the course of the week, Dave reported that he was in bed an average of 8 hours, 40 minutes. And of that, he slept an average of just 5 hours and 40 minutes. And his sleep efficiency was about 67%. So what Dave's telling us is before treatment, he is sleeping about 2/3 of the night, every night. And he's awake about 1/3 of the night on average. So this is the sleep diary of somebody who looks like they have insomnia. Very briefly, I'll mention one other assessment tool that might be really helpful for you in the settings in which you practice. If you don't have time to collect a sleep diary from patients, the Insomnia Severity Index, the ISI, is a quick and dirty 7-item patient self-report questionnaire, and it's really tapping into the patient's distress and level of upset about their sleep. To score it, you just add up their total number of responses. It falls into 7s, which makes it really easy. ISI of 0 to 7 suggests this is probably not chronic insomnia. 8 to 14 was subthreshold insomnia. 15 to 21 was clinically significant insomnia. That's moderately severe. And if it's 22 or up, that's consistent with severe insomnia. Dave's, I believe, was a 21, so right at the high end of the moderate range. So what caused Dave's insomnia? Well, as we've already mentioned, there are literally as many precipitating causes of chronic insomnia as there are human beings. In Dave's case, it was a combination of work stress and knee pain and knee surgery. For other patients, could be an episode of depression or anxiety. It could be work stress. It could be a job loss. It could be a marriage or a divorce or an illness. Something happens that pushes them over the edge into experiencing insomnia. So for most people, when they experience a stretch of time where they're sleeping poorly, they are going to try to actively manage that sleeping problem. And Dave was no exception to that at all. So here are some of the things Dave admitted to doing to try to manage his poor sleep when he was working and when he was rehabbing the knee. So one of the things he mentioned was he started going to bed earlier. He said, I need to go to bed early to make sure that I can get a good night's sleep. He started occasionally drinking alcohol before bedtime, just sort of help him to unwind. He started worrying about his sleep. He started wondering, is this going to be a good night? Is this going to be a bad night? And then every morning when he got up, his spouse and his teenage children would ask, how did you sleep last night, Dave? And that didn't help him at all because it started to sort of increase his awareness of his sleeping problem. Like many of our patients with chronic insomnia, Dave tried to sleep in, mostly unsuccessfully. More of what he was doing was laying in, but he would wake up at 4 or 5 and then lay there trying to get back to sleep. He also made some attempts to nap during the day. None of these things are unreasonable things. I would argue that good sleepers do all of the above all of the time. The problem is this: when someone has insomnia, the things that they do to try to cope with their sleeping problem have an unintended consequence. First of all, they disrupt what we call homeostatic sleep drive. Most patients need a good 16 to 18 hours alertness and activity and being out of the bed to build up enough drive to produce deep sleep. And so when Dan was lingering in bed in the morning, napping, going to bed too early, he was reducing his drive for sleep. Many patients with insomnia engage in behaviors that disrupt the circadian timing of sleep. So sometimes Dave would get up early, sometimes he would stay in bed later, sometimes he went to bed early, sometimes he stayed up later, and that created really a kind of jet lag syndrome. We call it social jet lag, so difficulty with the timing of sleep. And the things that Dave was trying to do to cope with his sleep problem created conditions of arousal, active mind, active body. So the worry about sleep was arousing, the poor sleep habits were potentially arousing, and most importantly, Dave began to develop what we call conditioned arousal. And I'm talking here about Pavlovian style conditioning. Pretty quickly, Dave's bed and bedroom lost their association with sleep because he was spending a third of every night awake in bed trying to sleep. He developed this conditioned wakefulness and arousal with the bed. So what causes chronic insomnia? There are as many precipitating causes of insomnia as there are human beings, but there's really only three causes of chronic insomnia, which are problems with sleep drive, problems with the circadian rhythm, and problems with arousal. So, what did we do to try to manage Dave's sleep? I'm going to skip ahead real quick because I know I'm going to run out of time shortly. What are we going to try to do to manage Dave's sleep? The American College of Physicians says all adult patients should receive CBTI as the first step in treating chronic insomnia. So what exactly is CBTI? CBTI is a brief, evidence-based behavioral treatment that's designed to target those perpetuating factors for chronic insomnia. We usually tell patients CBTI isn't a treatment, it's a collection of treatments. And for each patient, we are picking and choosing strategies that are going to help them. In our CBTI toolbox, there is one treatment that is specifically designed to restore sleep drive. And this is what's called sleep restriction therapy, or sometimes called time in bed restriction. We limit our patients' opportunity to sleep in order to restore their drive for deep sleep. The other behavioral insomnia therapy is called stimulus control, and it's designed to, number one, eliminate social jet lag by getting patients on a consistent bedtime and rise time, and it's designed to reduce arousal by reassociating bed with sleep. So when you do these two treatments in combination, you are addressing all three of the potential causes of chronic insomnia. Other strategies that people will use as part of CBTI mostly are designed to load onto the arousal side. So often we will do some form of cognitive therapy or training in counter arousal strategies. Relaxation or mindfulness may be part of CBTI. Sleep hygiene is sometimes part of CBTI. So what did we do for Dave specifically? Well, first of all, we initiated a trial of time in bed restriction. He was sleeping about 5 hours and 40 minutes. So we prescribed him a time in bed of 6 hours and 15 minutes. We asked him to do that for 2 weeks. We also did some stimulus control therapy to help him reassociate his bed with sleep. So we asked him not to get into the bed until he's sleepy, to use the bed for sleep only, and if he could not fall asleep quickly, to stop trying and get up. And here's what his sleep diaries look like after 2 weeks of treatment. So his average total sleep time is up only about 10 minutes. He's sleeping about 5 hours and 50 minutes, but much more efficiently with a sleep efficiency of 93%, which is actually in the sleep deprived range. 2 weeks later, we had extended his opportunity for sleep. And at this point, his sleep time is now 6.5 hours, which is solidly within normal range for a 66-year-old guy. And he still had sleep efficiency that was extremely high. Very briefly before I take questions, there are a short list of contraindications for CBTI. It's generally well tolerated. Patients who have current substance abuse disorders, patients who are psychiatrically or medically unstable should not do CBTI. If your patients have conditions like a seizure disorder or bipolar disorder, where sleep deprivation might be unsafe, they should not do CBTI. If they have excessive daytime sleepiness, meaning an Epworth of greater than 10, they're not a great candidate. And we do not do CBTI for patients with untreated or undertreated apnea because our treatment is not likely to be successful, and also because we may exacerbate their daytime sleepiness. That's all I've got. Are there questions we can take right now?
We have a few. Thank you very much, Dr. Danforth. That was excellent. So let me start by asking about exercise and difficulty sleeping. Can you talk a little bit about that and timing for exercise?
Yes, I certainly can. So exercise falls into the category of sleep hygiene. All sleep hygiene recommendations are based in basic science of sleep, and no sleep hygiene recommendations have been found to be effective for treating insomnia. Giving advice about exercise, giving advice about caffeine and alcohol intake, these are literally the sugar pill of insomnia treatments. And the American Academy of Sleep Medicine recommends that sleep hygiene education not be used for the treatment of insomnia.
So this one looks a little bit like a doozy, but I'm going to read the whole thing as quickly as I can. If a patient is unable to fall asleep after 30 minutes in bed, I've heard the recommendation to leave bed and do something else. While this may help with insomnia-related anxiety, does it also counter the natural production of melatonin? Could it also help to stay in the dark and rest, i.e. close and rest the eyes from stimuli, to support melatonin production / circadian rhythm, even though someone cannot easily fall asleep?
So this is a great question, and I do have a good answer to it, I hope. We do recommend that if patients don't fall asleep quickly, meaning 15, 20 minutes, that they get up, that they leave the room. Because remaining in bed, even if you're resting your body, remaining in bed is strengthening an association between bed and wakefulness, where we want there to be an association between bed and sleep. Now, patients get very bejiggity about this melatonin issue. They'll say things like, I can't turn on a bathroom light. What if it stops my melatonin production? Melatonin doesn't work that way. Your melatonin is secreted as a single bolus. It's an event that happens 2.5 or 3 hours before bedtime. It's called your dim light melatonin onset. It's not like a tap that turns on that runs all night. It's like flushing a toilet. Like you pull the handle, the melatonin is dispersed, and it's done. And so getting up in the middle of the night, turning on reading light, using your tablets or your iPhone or your Kindle is not going to disrupt your melatonin. That ship has sailed.
Thank you, Dr. Danforth. I had never associated release of melatonin as flushing a toilet. Gives me a nice visual, but thank you.
I'm so pleased to share that with you today, Atif.
Thank you. I think that is all the time we had, unfortunately, but Dr. Danforth will be joining us at the end of the day, so we can save some questions for then. So thank you again, Dr. Danforth. We're going to move on in our insomnia talks, and I am pleased to introduce our next speaker, Dr. Sush Arjal. Dr. Arjal is in the Department of Psychiatry. She's an assistant professor. And she's trained in sleep medicine as well. She's one of our go-to people for insomnia problems that occur in patients with other psychiatric comorbidity. So thank you, Dr. Arjal, and look forward to hearing your talk.
Thank you, Dr. Hussain, and thank you, team, for organizing this and for this opportunity. So I'm Sushrusha. I'm a psychiatrist and a sleep specialist, and I'm going to be talking about medication management of insomnia today. So let me just start with this slide. Okay. So in the middle of the pandemic, I think most of us can relate to this. With struggling to fall asleep, stay asleep, waking up early in the morning, and impaired daytime functioning. That is the criteria for insomnia, and I'm sure Dr. Danforth has elaborated that, so I'm not going to go in detail about the diagnosis of insomnia.
Dr. Arjal, sorry to jump in, but can you go to a full screen for your slides?
Okay.
Bottom right. A little to the left.
It's to the left of the zoom in and out bar. The very first icon to the left of that, in the bottom right-hand corner.
Sorry,
No worries. Here.
Okay. Okay.
Thank you.
Thank you. So yes, this would be Thank you, Victoria. So this would be the ICSD-3 criteria for insomnia. And just very briefly to, the introduction of insomnia. So persistent sleep difficulty, sleep onset and sleep maintenance, waking up early in the morning, adequate sleep opportunity should be there. If someone has a 5-hour commute and doesn't have an opportunity to sleep, then that's really, doesn't fit the criteria. And it should be associated with daytime dysfunction. So what it means is if somebody is sleeping 5 hours for the last 20 years and is doing just fine, no need to medicate that person, right? And I'm sure, again, Dr. Danforth is an expert on that. So, okay. So I want to take this opportunity to talk about different medications that have been used for insomnia. Some of them are FDA approved, some are not FDA approved, but have been used clinically and patients have found it to be beneficial, the different categories. So we'll kind of go over, and I'll try to accommodate the risks, benefits, and side effects for these different ones and medications. And if something is left, I can always take questions. And we'll also talk about medications that are used in insomnia when people with other different comorbidities like sleep apnea, COPD. So we'll go from there. So these are the FDA-approved medications. The categories would be benzodiazepines, the famous benzodiazepines, right? Benzodiazepine receptor agonist, which we also called Z drugs. The antidepressant, among the antidepressants, doxepin is FDA-approved. There are other antidepressants which we use for insomnia, but they're not FDA-approved, like mirtazapine. So we'll talk about that too. Serotonin receptor agonists like Ramelteon, 1 and 2 are the receptors. So agonist Ramelteon, which would help people to fall asleep and stay asleep. And then the orexin receptor antagonist, which would be suvorexant and lemborexant. So lemborexant is a fairly new drug. It was just FDA approved in December 2019. So I want to elaborate a little bit on benzodiazepines. So both benzodiazepines and non-benzohypnotics, they work on GABA receptor. So GABA receptor has different parts, so to speak, right? The GABA A and GABA B, and both benzodiazepines and non-benzohypnotic work on the GABA A. So they enhance the effect of GABA and they help, with the muscle relaxation, they help like people to fall asleep quickly, which in technical sleep terms we say decreased sleep latency. They also would decrease the arousals over time, during the night. So that's why they are very popular in a sense, like, people like them and people want to use them. However, benzodiazepines and both non-benzos, hypnotics, have a property of tolerance, which means that you want to use a higher dose to have the same effect over time. So that's how even for the short time, it's effective. And then once you start using it for a long period of time, it eventually becomes, ineffective, and eventually the risks become higher than the benefit, right? So they're really not recommended for long-term use. Having said that, and I'll be happy to take questions on this, but having said that, in the clinical practice, we see a lot of people who are on benzodiazepines and very hard to come off benzos, But anyways, so talking about different benzodiazepines, so as you can see, these are different benzodiazepines with different half-lives, right? So with the medication, one of the things that we want to remember is anything that has a short half-life can be used for sleep onset insomnia and will have less tendency of making people sleepy the next day. Anything that has a longer half-life is usually used for sleep maintenance insomnia. but then will come with the side effect of making people drowsy, impaired driving, and all sorts of hazards, and maybe increased fall risk too, because it's in the system for a long time. So we might want to just kind of take a look at this list and see, like triazolam, it has the shortest half-life. So this is a good medication for sleep onset insomnia. Maybe not so much for sleep maintenance insomnia. Lorazepam and temazepam, they are mostly used for sleep onset and sleep maintenance insomnia, because the half-life is somewhere like in the middle, right? Lorazepam, midazolam, I haven't seen them being used in the clinical practice, probably because of the long half-life and excessive sedation, and so probably not worth it. And now we come to non-benzodiazepine, the hypnotics, and these are the list. The esopiclone, it comes in like 1 to 3 milligrams, half-life of 6 hours. The xalapalone, which has the shortest half-life of just 1 hour. Zolpidem, 5 to 10 milligrams. So zolpidem, if you look at zolpidem, the guidelines have changed for the prescription for males and females. For females, the dose is lower, actually half of the dose of what we prescribe for males. So 5 to 10 milligrams for males, only 5 milligrams for females. And zolpidem ER also similarly 6.5 for females and 12.5 for males, so it's the extended release. There is one intermediate release version of zolpidem, which has a half-life of about 1.5 to 4.5 hours, and meaning this is a medication that you probably will be okay, like taking it in the middle of the night, and as long as you have some few hours to go back, to sleep. Should be fine. Zopiclone is not a medication that is available in America, but this is also among the category of it falls in the hypnotics category. So among the non-benzos hypnotics, if you have to pick the safest, would be xalapalone because of the short half-life, right? However, this doesn't help people stay asleep. That is the main, problem with that. And in clinical practice, it's really not. People don't, like it as much for sleep maintenance, of course. So that would be another thing. So, talking about the effects of both benzos and non-benzo hypnotics, see, daytime sleepiness is one of them. Dizziness, headaches. The fall risk is very high, especially for the benzos, from hip fractures. And especially when we consider the risk, we should consider the population, and the risk is highest in the elderly population. So we're not supposed to prescribe above 65 anyway because of the fall risk, especially the benzodiazepines. I'm sorry, I'm not talking about non-benzos hypnotics. They have been used, but for the benzodiazepines. If we talk about non-benzos hypnotics, see, the risks are a little bit similar, but lower. And the risks of withdrawals are also lower. If you look at the risks of withdrawals for the benzodiazepines, they can range from, whatever is the effect of the drug, the withdrawals would be the opposite, right? So muscle spasms, in extreme cases, like, agitation, muscle spasms, in extreme cases, seizures, even DTs, which is the delirium tremens, can be the withdrawal effects of benzodiazepines. For non-benzos hypnotics, the withdrawals are not as bad. However, if you are using these medications for a long term, we will need to taper it off. And over the period of few weeks, few months, and patients can feel the withdrawals for a couple of years. So it is definitely a hard process to kind of go through for both you and the patient, especially if we have tried it for a long period of time. So this is the structure of GABA receptor. I just I like this picture, and in a sense, like, it gives us an idea of like how gamma receptor looks like, what are the different components, and where do they work. And I kind of try to educate my patients that see, alcohol works on gamma receptors, and alcohol has tolerance and it has withdrawals. So we wouldn't want to recommend alcohol to sleep, right? So that's why, like, even benzodiazepines, we would want to recommend for long term to sleep. This, so that kind of helps sometimes. Okay. So the golden rule, first line of treatment for chronic insomnia is CBTI. As hard as it sounds and as difficult as it to convince somebody who is suffering from severe insomnia and wants to be treated like immediately, medications are not as effective in the long run as CBTI is, So these medications, the ones that I mentioned, the benzos and the hypnotics, are ideally supposed to be used for acute insomnia, which is the insomnia that lasts for about 3 months or less. And we're supposed to use it for like 2 to 4 weeks and taper it off in an ideal world. So there are other drugs for insomnia that we use, as I had mentioned. Doxepin is one of them. Doxepin is FDA approved. It is an antidepressant. It works through the histamine receptor antagonism. So histamine receptors can make you awake, right? Again, the opposite effect of that, whatever kind of antagonizing histamine receptors can make you sleepy. 3 to 6 milligrams is the recommended dose. With the doxepin, again, the daytime sleepiness is more because of the increased half-life. Ramelteon is the melatonin agonist. It comes in about 8 milligrams. Half-life is about 1 to 2.5 hours. Ramelteon is a good medication for people who have melatonin because the receptor affinity for Ramelteon, for the melatonin receptors, is higher than the melatonin. But again, if people have already, and this is my clinical experience, have already been on benzos and hypnotics, they usually don't like melatonin, and they say that it does nothing for me. So that's another challenge we run into. So suvorexant. So suvorexant and lemborexant are a completely different kind of medications for insomnia. There is a receptor called orexin receptor. When the orexin receptor in our brain is missing, what happens is we have narcolepsy. So what it means is it keeps you awake, right? This receptor. So if we find a drug, which they have found, to antagonize these receptors, then like controlled, in a controlled setting, probably you can make people sleep. And that's exactly what happens. They make people sleep. And this is a drug for insomnia, right? So the suvorexant has the property of, so it has a very long half-life, as you can see. So it can be used for sleep maintenance insomnia, not so much for sleep onset insomnia. Also, suvorexant, because remember, it antagonizes the orexin receptors, and absence causes narcolepsy. So what would be the side effects? It would resemble side effects of narcolepsy, right? Sleep paralysis, excessive sleepiness during the day. So for suvorexant, we recommend that patients have 7 hours in the bed before they take the medication. And this is not a medication that we want to wake up in the middle of the night and take, so that is something to be, kind of mentioned to the patient, and they should be educated about that. Other recent medication for insomnia is lemborexant, which is like suvorexant, but it, instead of antagonizing just one receptor, it is a dual receptor antagonist. It was FDA approved in December 2019. Side effects are kind of similar, but it's a very new medication. So I think more is to come for like how it would be different or similar, and all that. So. Okay, now let's talk about the drugs that are used off-label. So the off-label medications would be, we use trazodone a lot. However, trazodone is not FDA approved. It can, and it has been, and I will mention that it has been studied in inpatient settings. And clinical, when I say we use, means patients like it, even though it's not FDA approved for sleep maintenance insomnia, and it can come with a couple of side effects that are very unique to trazodone. Would be orthostatic hypotension, which would mean that the blood pressure drops suddenly, right, when you stand up. So that would be one side effect of trazodone, and excessive sleepiness during the day, because it has a long half-life. But people are on trazodone. 2,400 milligrams is the dose. For antidepressants, the therapeutic dose of antidepressants that is used for insomnia is way less than the therapeutic dose of, that we use for the depression. So in lower doses, they tend to work against the histamine receptors and make people fall asleep, But if you have to treat the depression, it goes doses are really high. And one thing one other antidepressant is mirtazapine too, which we use off-label. So mirtazapine is used in the doses of 7.5 up to 30 milligrams. But the antidepressant dose of mirtazapine is 7.5 up to 45 milligrams. So that would be medication which is not FDA approved, but we do use it, especially in people with depression and insomnia, and it's a good medication. With the mirtazapine, if I have to say that there is one side effect that is very common, is increased appetite and increased weight gain. So mirtazapine causes weight gain through increased appetite. So if our patients start eating very high calorie food and just kind of out of ordinary after starting mirtazapine, you want to attribute that to the drug, and then just to kind of take the patients off. But once you take the patients off, the weight loss, weight gain kind of generally comes back to normal. So that's about antidepressants. The antipsychotic. So quetiapine is an antipsychotic that is also frequently used off-label for insomnia. And again, with quetiapine, the problem is the weight gain. It can cause severe weight gain, and its weight gain is dose dependent. So higher the dose, it's the weight gain. 25 to 400 milligrams have been studied for insomnia, and from 200 above is the antipsychotic dose. So this is a medication, when we, because I'm a psychiatrist as well, so when we treat people with acute psychosis and who are also struggling with insomnia, it's very ideal that way. But then we will have to educate them about the weight gain part of it. So antihistamine, diphenhydramine is not FDA approved, but if you take sleep history, a lot of people have already taken diphenhydramine for some time before they come to you. So very common and very popular over-the-counter medication for insomnia. So just to kind of go over some of the research that's out there on medications for insomnia, among the FDA-approved drugs, only is sulfone. Remember that medication which we use for sleep onset and sleep maintenance insomnia, this is the only medication that has been approved for the long-term use up to 6 months. Rest of them were for less than 35 days of use, and this is just another, study. Estapaglone has also been studied in patients with mood and anxiety disorders, and it has been found that it's helpful to help that, to help with insomnia in patients with mood and anxiety disorder. So let me just keep track of time too, but okay. So substance use and insomnia. In psychiatric practice, we encounter a lot of patients with substance use and insomnia. insomnia. Problem with substance use is then you cannot prescribe, and ideally you shouldn't prescribe benzodiazepines, right? Or even hypnotics. So we use like trazodone, quetiapine, gabapentin, naltrexone, rebeltone. These have been studied, and in my clinical practice, I found that quetiapine works very well. So some evidence in cocaine use, modafinil has some evidence in patients with cocaine use to treat their insomnia. Geriatric population, CBTI and CBTI, because they have so much already they have a lot of comorbidities. So CBTI would be the patients with PTSD, prazosin starting 1 milligram up to 10 milligram in the population. It works through adrenergic blockade. So, there are some studies that gone against this statement, but so far prazosin is saying that we really clinically use for nightmares for PTSD. These are some other medications that have been used for PTSD, insomnia in PTSD, gabapentin, topamax, timazosine, olanzapine, which is an antipsychotic, risperidone, which is also an antipsychotic, and trazodone, which is an antidepressant. Psychotic disorder, again, esopiclone has been studied and found to be helpful, CBTI. In the inpatient setting, trazodone has been used quite frequently and have found to be helpful, and as I had mentioned. Again, melatonin has also been used. And in other comorbid sleep disorders like esopiclone had improved the CPAP adherence. And in people with restless legs, because of the sedating effect of gabapentin, pregabalin, these are used quite frequently. Chronic kidney disease, zolpidem, zalpulone, there's some evidence of clonazepam. COPD patients, generally we avoid medications because of the respiratory depressant properties of those medications, but CBTI is the sign. Antidepressants, melatonin, and gabapentin have been found to be helpful in different studies. In pregnancy, CBTI again, but doxylamine and diphenhydramine can be used. But again, this depends on if you are treating mood disorder as well, you have to weigh the risks and benefits, because if somebody is on antidepressants like mirtazapine and is benefiting from that, you have to really assess the patient before taking them off. But it is not recommended for insomnia only. So in menopause, CBTI, venlafaxine, gabapentin, exopiclone, and escitalopram are the medications that are. Escitalopram is antidepressant, and I think we talked about the rest of it. And venlafaxine is also an antidepressant. So these have been studied and found to be helpful in patients with menopause. So I rest my case here, and if you have any questions, I'm happy to take them.
Great. Thank you very much, Dr. Arjal. That was excellent. There's a number of questions. Let me start with one. There's a question about zolpidem and zolpidem ER. They seem to have comparable half-lives, questionnaire asked, as per their evaluation or their studying. What is the difference of onset of action of the two drugs? And is it really beneficial to take an ER formulation? When do you use one? When do you use the other?
So that is an excellent question. So yes, their half-life are comparable. That's correct. But zolpidem ER, extended release, is the controlled release. So it releases slowly and slower. It stays in your system more than the zolpidem. Clinically, if you see, generally, if I switch the patients to zolpidem CR, it helps with sleep maintenance, insomnia. But both zolpidem, they are kind of comparable in some ways. But if one doesn't work, I'll switch to the CR form. And then it helps with sleep maintenance, insomnia. Sometimes people have this, excessive sleepiness on CR versus the zolpidem in spite of the comparable half-life. And I attribute that to the controlled release of, the zolpidem.
Ooh.
A lot of questions.
There's a lot of questions. So in the inpatient setting, what are your top 2 medications and dosages you usually recommend for patients who have acute difficulty sleeping in that setting specifically? Hospitalists default to Seroquel, but it concerns our questioner. Do you have any advice?
Well, it depends on when you say the acute inpatient setting, like why is the patient admitted? If the patient is admitted for depression and is in the severe depressive phase, mirtazapine would be the medication to go because it helps with depression and it also helps with insomnia. If the patient has psychosis and is admitted because of that, then quetiapine would be the medication to go to, and benzos are not, off limits. If you know that it's inpatient setting and we need to, because remember, sleep is very important. It is one of the markers to, check for the risk assessment of suicidality, right? So we need patients to sleep. So in acute inpatient setting, it's really not off limits to use benzos and try other medications too. But if you say 2 medications, that would be like, it all depends on the situation. Why? But those are the medications we often use, yes.
Great. I think that's all we have time for. Thank you so much for your presentation, for answering a couple of our questions. Our next speaker is someone who...
Thank you very much.
Yeah, absolutely. Our next speaker is someone who might look a little familiar. Dr. Spector is coming back for a second presentation, sleep disparities in healthcare with sleep patients. Dr. Spector. Perfect. And while he's pulling that up, as a reminder, Dr. Spector is our Vice Chair of Diversity and Inclusion here in the Department of Neurology. So we're really excited to have him give this presentation.
Okay, thanks, Victoria. All right, so thanks for having me back a second time. This time we're going to talk about sleep disparities with regard to race. And so let's jump right in. I have no disclosures. The objectives for this lecture are to define what health disparities are, review sleep-specific health disparities, and then discuss causes for those disparities, and then some tips that you can take back to your practice to try to improve them. So the definition is provided by the CDC is that health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. So what is a socially disadvantaged population? Well, actually, it's defined on any of these 10 demographic variables and social variables. And any of these could be considered a social disadvantage. Today, we are going to speak specifically about race. And we're going to focus on race as the disadvantage and how it affects health. Well, now we have to define race. So what is race? In the United States, the official races are these 5. In the United States, you can be white, Black or African American, American Indian or Alaska Native, Asian or Native Hawaiian or other Pacific Islander. This is exactly what the United States Census says. These are your choices when you complete the census. So although there are many possible objections, this is how the United States officially classifies people. Hispanic does not appear as a race. It is considered in the United States to be an ethnicity, so it doesn't appear on this list. But let's take one. Let's say Asian. That's one of the 5. And let's look at Asia and decide if that is really a category that makes sense. We have to imagine that when people say they're Asian by race, that doesn't necessarily imply that they're from parts of Asia where they would otherwise look and present as white. So maybe we're looking at places like India or China or Pakistan or Indonesia, but are people, and we're talking billions of people, is that one race? And if you were in those countries, would you all be considered one race if you came from different countries? So there's problems with the terminology we use. But for the interest of this talk, we sometimes stick with the language that's been used in the research. So the definition of race that I'm going to use for today is a construct used to organize people by physical appearances for the purpose of exerting power. And it's important to remember the power aspect of race, because race came into existence as a concept for the purpose of justifying the hierarchies of different populations. So when people decided who was going to have the power and who was not going to have the power, who were going to be the slaves that were sold across the ocean, race was used as a justification. And so this was not based on any sort of science or data. It was a convenient way of categorizing people to put some people at the top. So that's what I mean when we talk about race. It's physical appearance, if not more than anything else. And the terminology, I try to stick with the terminology as I talk about this with what was used in the study, because it makes a difference, because a lot of studies use self-identified race. So people tell the researchers what race they belong to. And so it's important to know how people self-identified in those studies. But you know, we sometimes use Black, and we'll use African American, white or Caucasian. When I'm speaking today, I'm going to tend to use the first word on the left in each of those categories. That's what we'll see most in most of the studies that we're going to talk about, and the one I think is most apt because it is the most common in the United States is how we refer to people. I want to spend a little bit of time talking about why I'm focusing on race. When I showed you 10 different ways you could have social disadvantage, why am I going to focus specifically on race today? And a lot of that comes from data like this. This is life expectancy stratified by income. And on the right, you'll see the group that makes 400% of our federal poverty level, and on the left, less than 100% of the federal poverty level. So as the columns move to the right, these are people making more and more money. And then the blue bar is Black, the red bar is white, the green bar is Hispanic. And what you see is the number of years a person is expected to live after age 21. And despite making as much as their white and Hispanic counterparts, Black people actually live several years less. In fact, if we look at the Black group making the most amount of money, they're living about the same number of years as white people in this second group here. So when we talk about income, income is certainly a risk factor. As you can see, every group goes up in terms of life expectancy with income, but even as you go up with income, you lag behind in the life expectancy if you're Black. So there's something about being Black in the United States that's shortening lifespan. Same holds true for education. There's a general trend that with more education, life expectancy gets longer. But at each level of education, you see that Black Americans are lagging behind white and Hispanic Americans, such that Black Americans with a college degree are expected to live a shorter lifetime than white Americans with a high school degree. So again, there's something here that we need to look at, because this isn't just education, this isn't just income, there's something independent about race, and that's why we're talking about it. So with that being said, I want to transition into specific sleep-related talk now about what are the racial differences we see in sleep health. And I'm going to just put one slide on COVID-19. I don't want to ignore it, but there really isn't a whole lot of data yet on racial disparities in sleep health during the pandemic. We do know that the pandemic is significant insomnia and sleep difficulties, and it's also made it harder for people to procure regular health care. We would expect from this that there's going to be a differential effect based on race, simply because COVID-19 has affected some groups more than others. But we don't have empirical evidence for this yet. So we'll wait and see how the pandemic plays out with regard to sleep, but we don't have any studies yet. Sleep duration, this data goes back to 1990, long before we were worried about COVID-19. It was actually published in 2007 based on 1990 data. What we're looking at is a graph of how long different racial groups sleep. And you can see there's one outlier here at the 7 to 8 hour range. And 7 to 8 hours, this is normal, this is healthy sleep. And the one outlier here is the Black population in the study. they were more likely to sleep longer and shorter hours. They're the highest on the long side and the highest on the short side, and they were the lowest in the middle. This was 1990, but it was repeated, a similar study in 2005 that showed the exact same findings. You can see in this study of white and black subjects, in the short duration sleep of less than 5 hours or 6 hours, you can see that the black subjects slept, were more likely to sleep these short hours. And then on this side, the black subjects were more likely to sleep the long hours. And in the 7 to 8 hour range, you can see it flips. White subjects were less likely the black subjects were less likely to sleep these hours than the white subjects. So being black was more predictive of extreme sleep in this study than anything else they looked at, including medical conditions, income, sex, age, or geographic region. The one trend they found more than any other was that the black race was associated with these differences in sleep duration. Those were self-reported sleep duration. This is actually objective sleep duration using actigraphy and polysomnography. So our two sleep tests that can determine sleep objectively. Black subjects averaged about 30 minutes less sleep than white and Asians who were grouped together in this study. And sleep efficiency was lower in black subjects. The percent of stages REM and N3 sleep were lower in black subjects. And it was not related to sleep apnea because their AHI, a measure of the severity of sleep apnea, was not significantly different. So they found all these differences in the sleep of their black subjects versus the white and Asian subjects. This is not, however, true throughout the lifespan. In this study of children, parents were asked, do your children ages 6 to 9, 10 to 13, or 14 to 17 sleep commensurate with what they should be sleeping at that age group? So researchers told the parents, is your 7-year-old sleeping a certain number of hours a night, like 10 hours a night? And 30% of the white parents would say no. 38% of the white parents of older kids, and 49% of these teenage parents, these parents of teenagers, were saying no, their children did not get the recommended hours of sleep. So it was not true in the Hispanic Black families, where they reported less likelihood of achieving inadequate sleep. So what this tells us is, again, this is not a biologically fixed component of sleep, because somewhere between childhood, where the white kids aren't getting enough sleep, and adulthood, where the black adults aren't getting enough sleep, something is changing. So it makes it really unlikely that this is anything innate about black people. When we look at the trouble with reaching a healthy amount of sleep, we're wondering, is this deprivation, which comes from external factors, or insomnia, which is more internal factors? And really, the rates of reporting insomnia are not significantly different between white, black, and Hispanic populations, although the Chinese population in this study reported less insomnia. But it doesn't seem to be that insomnia is driving this. There are external factors that seem to be more at play. Let's look now at sleep apnea, switching gears a little bit because I don't want to spend all the time talking about just black and white disparities, because in fact, in sleep medicine, there are other racial health disparities. And in this case, I want to talk about Chinese health disparities. So as you'll see, on the left here, this is known sleep apnea. So in this population, they asked, do you have a diagnosis of sleep apnea? And similar rates in white and black populations said yes. The Chinese subjects, only 3% of them said yes, they had known sleep apnea. But then they put the whole subject pool in the sleep lab. They did a sleep study, and they found, lo and behold, 18% of the Chinese subjects had severe sleep apnea, and only 3% knew they had sleep apnea at all. So the biggest percentage of missed cases was actually the Chinese population here. 14% were missed. Most likely, this is related to BMI. And when we look at this, in Chinese populations, the average BMI is 24 compared to 30 to 31, 30 or 30.1 in the black and Hispanic populations, or 28 in the white population. And this discrepancy in BMI is most likely why it was not detected in Asian populations in this Chinese population because BMI is so strongly correlated to the presence of sleep apnea in white and Black Americans. So for Chinese Americans, where BMI is not as strong a predictor, it was being missed. And you can see that here in this graph. So this is a chart where white is used as the baseline, and Black, Hispanic, and Chinese subjects are compared to white, and what are the odds ratios of having sleep disordered breathing if you are normal, overweight, or obese. And you can see if you're Black and normal weight, your rate of sleep apnea is exactly the same as white, and similar rates really all along for all weights for Black people. But skip here to Chinese, and you're going to see how much more likely you are to have sleep apnea if you're normal weight and Chinese than you were if you were white. Again, Hispanic did not reach significance at any level, just like Black, but the Chinese at normal and overweight reached significance in terms of the odds ratio of having sleep apnea compared to the white population. And so this is a significant problem because severe sleep apnea that's being missed so readily leads to all sorts of health problems. And you've heard about them in the previous lectures from my colleagues. But by missing such a high percentage, we're really missing a chance to help improve the health of Chinese patients. Similar studies have been done in other populations, for example, Korean patients. So this actually holds true. I'm not showing that data for the interest of time, but it's not just Chinese. There are other Asian populations where this would hold true as well. Now let's look at CPAP adherence. This was a review of 22 studies from 2018, many of which were deemed low quality. 7 included races other than Black and white. Only 11 had sample sizes over 100, and only 5 had a majority of women. So the authors of this review deemed it low quality evidence. But that aside, the bulk of the data from the review did suggest that there were fewer nights of use and a shorter duration of use per night for Black versus white CPAP users. But when they controlled for the neighborhood socioeconomic status, that mitigated the effect. So what they found is not that Black people were inherently less likely to use CPAP, more likely that there were environmental circumstances regarding the neighborhood and socioeconomic status that were controlling this, that it was really not just a Black and white issue. Because white CPAP users would show the same effect. They were just less likely to live in a lower socioeconomic neighborhood. So what is the cause of these racial disparities? We can look at nature and we can look at nurture. And I've alluded to some of the issues with genetic etiologies already, but I want to spend a little bit of time talking about genetics, comparing it to the nurture hypothesis for racial disparities. Let's look at genetics of African Americans in the United States. And these graphs are sort of mirror image graphs. What you're going to notice is the lavender purple colors here, that represents mean African ancestry. So the researchers used markers in DNA to trace back to see where the bulk of the DNA was coming from in self-identified African Americans. And South Carolina here, the darkest color, showed the highest rate of African origin DNA in this study, compared to West Virginia, where self-identified African Americans showed the highest rates of DNA that had been derived from European populations. So I show this to show just how difficult it would be if you were doing research to make any sort of genetic assumptions based on self-identified race. This is similar data presented in a different way. And the blue bars here represent self-identified African Americans. The red bars represent self-identified European Americans. And across the x-axis, you're going to see a higher proportion of African ancestry. And as you reach the higher proportions, as you'd expect, these people with 100% DNA that the researchers determined had come from African populations were much more likely than those with 0% African origin DNA to identify as being African American. However, you're going to see some people here still identify with the race with which they have very low percentage DNA. So it just goes to show that the physical attributes and how you look and how you're treated and how you're raised can have a lot more to do with how you identify than anything having to do with your genetics. And this group here, where the bulk of the transitional groups, you can see it can be almost 50-50 based on your DNA, which way you would identify. And so again, trying to do research based on self-identity really is not going to get you any information about genetics. So the studies that claim they're using, there's something about race, really there's nothing biological about that. So let's look at nature or nurture. Again, this is a study on Alzheimer's disease because we don't have a similar study from the sleep literature. So I had to pull something from the neurological literature. And I really like this study because it's looking at the Yoruba population from Nigeria and African Americans in the United States and risk of Alzheimer's. You can see here on the right, the overall rate of Alzheimer's disease is substantially higher in African Americans in the United States than it is in the Yoruba population in Nigeria. And this is not a reporting issue because this is not pulled from some database. These researchers were the same researchers that went between the two countries, studied a large population, and made their own diagnoses, and they found simply lower rates among the Yoruba population. And why did they choose the Yoruba population? Because when you look at this map, you're going to see right here, this is Nigeria, and this is where the Yoruba live, predominantly southwest Nigeria, the highest concentration of the Yoruba, and that's a large percentage of where the American slave population came from. And thus, if we were to see a genetic underpinning for Alzheimer's that way, we would expect similar rates in the African Americans who were brought here from Nigeria. And we don't see that. So again, we don't really have a biological explanation that links all Black people to say that this is something that's true of Black people as a whole. What we have are various aspects of social determinants of health, and I think you've probably heard that term. These are the acquired causes of sleep disparities that affect populations aside from biology. And I want to focus specifically on chronic stress, because chronic stress is the category in which I put things like racism. So specifically perceived discrimination. This study included both African American and Caucasian subjects, and they asked these subjects how much they experience unfair treatment, how much they worry at night, do they experience anxiety, depression, or hostility. And they showed that the African American subjects reported more unfair treatment than the Caucasian subjects. And that was the only one where there was significant difference. The rest were the same among the groups. But there was a higher rate of unfair treatment among the African American subjects. And what did that mean for their sleep? After adjusting for age, sex, BMI, socioeconomic status, hypertension, and even adjusting for race, unfair treatment alone in both white and Black populations resulted in poor reported sleep quality, daytime sleepiness, shorter sleep duration, lower sleep efficiency, and reduced REM sleep. So what this is telling us is that unfair treatment leads to bad sleep. And as I showed on the previous slide, Black people were more likely to report that unfair treatment. So this is something that will disproportionately affect them. Then we've got the chronic everyday discrimination scale. This is another way of looking at a similar concept. And those who report higher rates of discrimination also have higher scores on the PSQI, which is a measure of sleep disruption. So higher discrimination subjectively led to worse sleep. Objectively, using polysomnography, looking at wakefulness after sleep onset, those reporting higher degrees of discrimination also showed higher amounts of sleep after, higher amounts of wake after sleep onset. So both subjectively and objectively, chronic everyday discrimination led to worse sleep. In another study of ethnic experience, using the ethnic experience scale, this is another way of getting a perceived discrimination score specifically related to your ethnicity, as opposed to the chronic everyday discrimination score, which can be discrimination based on other things besides just race. But in this case, this was the scale of ethnic experience, and they controlled for age, BMI, socioeconomic status, and smoking. And it perceived discrimination led to less stage N3 sleep. Now that's really important because stage N3 sleep is the physically restorative aspect of sleep. You have low sympathetic activation. This is when your immune system is reconstituted. This is when you get that deep restorative sleep. And if you take that away, it's not a stretch to understand that there are going to be health consequences from that. And I show this slide every time I talk about health disparities in any context because it's just amazing to see. When you compare subjects in the 95th percentile of perceived discrimination compared to the 50th percentile of perceived discrimination, you see markedly higher risk of death, all-cause mortality. This is just 6 years of tracking people. You're already starting to see those who are experiencing higher degrees of discrimination in their lives are dying. So what are we as healthcare providers doing to contribute to these disparities? And this is, these are things to keep in mind as we're practicing. There can be plenty of unconscious discrimination. And like I said before, Chinese Americans who aren't being diagnosed with sleep apnea because their BMI is normal. We're not factoring in their own risk factors when we do that. And this isn't conscious. I'm sure these providers have no ill will toward their patients, except if you don't pay attention to the disparate risk factors, you may miss this. But then there's the overt racism. I mean, if you don't believe that Black patients are able to understand what you teach about sleep apnea and you provide them less education, that's how overt racism can worsen health outcomes. And then there's the concept of stigmatizing language, and I'll give an example. So using this quote in a note, for example, he is narcotic dependent and in our ED frequently, versus he has about 8 to 10 pain crises a year for which he typically requires opioid pain medication in the ED. And the first one is just clearly more judgmental. There's a lot of emotion and stigmatization going on in that first statement that just doesn't occur in the second one. And even if your practice is identical, no matter how you write your notes, you might be influencing the next doctor who comes along and sees that patient and reads the note before they see the patient, and they read about narcotic dependence and frequent ED use, and already you've set them down a different pathway than you would if you'd said it the other way. So just as a summary, racism in healthcare can be composed of unconscious discrimination and overt racism, as well as the stigmatizing language, and we need to be on guard for all of these. And I spend a lot of time talking about racism, even though this is supposedly just sleep disparities, because I need to impart the idea that racism is not just a quote, social problem. It's a medical problem. People experiencing more discrimination and racism are at risk for premature death. Racism kills people. And so what can you do? Good healthcare must not be colorblind. We need to actually account for race to provide equitable care, because people of different races have different social determinants of health, are experiencing more racism, and there are more obstacles to care. And we need to be aware of that and account for that in our practice. We need to be able to look at our notes. Go through your notes when you're doing your next quality improvement project or your maintenance of certification. See if you can find stigmatizing language and then make a change. You can analyze your charts to make sure that your practice is the same across different races. And there's no number of times I can say this too much. It's racism, not race, that's a risk factor for disease. I'm going to end there and take any questions. Thank you.
Thank you so much, Dr. Spector. Dr. Hussain, do you want to start off the question and answer?
Sure. First question, excellent review of the issues of racism in healthcare. How do you address healthcare disparities in your practice, and especially in terms of a sleep practice, Dr. Spector?
Well, so I'm going to give an example. This is a true story. This happened yesterday, and I was wondering how I'd be able to work this story in. I got a text message from a colleague in primary care telling me they an elderly patient with insomnia, he didn't want to prescribe a hypnotic, and what would I recommend? And I said, cognitive behavioral therapy. And I got a laugh in response. This patient's not going to be able to do cognitive behavioral therapy. too poor, too old, not enough resources. And, my reaction to that is, we don't want to be the ones judging what our patients can handle. He was worried she wouldn't be able to attend the sessions. But I said, look, she came to your office. If she can make it to your office, she can make it to the psychologist's office. So we need to make sure that we don't choose for our patients what they can and cannot do. And we need to be aware that we're offering the standard of care to every patient every time.
As a follow-up to that, Dr. Spector, one of the studies you talked about lower socioeconomic status and its impact on CPAP compliance specifically. Could you speak a little bit to how you encourage your patients potentially who face those types of difficulties and how they can be more compliant with their CPAP machines, or what issues they might be facing?
Yeah, so there's a big problem with health insurance in this country, and without getting too much on a soapbox about health coverage, what we know is that CPAPs are expensive and CPAP supplies are expensive. And so I see people coming in and I hear stories about, they're living in an insect infested apartment, and the insects got into their CPAP. Can they get a new one? But their insurance, even if they have insurance, isn't going to cover it. I mean, this is a major problem. If you have a problem with your CPAP mask and it's not comfortable, your insurance will buy you one every 6 months. But what are you supposed to do in the meantime? Masks can run anywhere from $60 to $160. And so if you don't have that cash to spend on buying yourself a new mask, you're out of luck. So thankfully at Duke, we're able to help people, and we can provide some supplies in the meantime. But this is a problem across the country, just in terms of access to healthcare based on what insurance are able to provide and what patients are able to get. And that's if they have insurance at all.
So Andrew, we have time for, I think, one more before our break. At the end of your slide deck, you had the phrase, and hopefully I'm not going to get this wrong, that it is racism, not race, that is the risk factor for disease. But are there not biological risk factors that differentiate the races?
There actually are not. And I took this slide out because I was going to run out of time. So about an hour ago, I took this slide out, but they looked for this. So the definition of a race is 25% variance between groups. And they can find this in chimpanzees. So if you study different populations of chimpanzees, you can actually identify by looking at the DNA. What we have in humans is not actually different races. You can't find anywhere near that genetic distinction. What we have can actually just be they're populations that you can distinguish, just like you could potentially trace your ancestry the way Ancestry.com or 23andMe, these genetic sites, they locate your ancestry, and they can do that, but not by race, not by skin color. It's actually, if we were to break it down, there would be thousands of these different populations. So if that's what we want to use as a definition of race, there would be thousands of them. But genetically, you can't actually look at someone's DNA and identify what race they are. There is no actual marker that we've ever identified where you can do a study and know what skin color that person has or what their phenotype would be. So really, no, there is no genetic way to determine race.
So just to follow on from that, basically, are you then saying that people who carry around this notion that hypertension is more common in the Black race, that is in fact incorrect, or that microvascular disease leading to subcortical strokes and such in African Americans is actually the wrong way to look at it?
Well, so it's definitely true that being Black is associated with having a higher risk of those conditions, but it's not because they're Black, it's because of the environment that Black people are living in the United States. So, and this is not entirely mitigated by things like wealth. As I was showing at the beginning, there's discrimination, there's racism, there's access to care. There are all sorts of factors that contribute to that. So while it's true, there are disparities by race, it's not because of the race. it's because of the environment that people of that race are living in.
Well, thank you, Dr. Spector. This is a very interesting and thought-provoking topic to end this segment on. We are up for another break, and we will return at 1:35. Victoria, is that correct?
That is correct, with Dr. Wasim's presentation on restless leg syndrome.
Lovely. So please something to eat or drink or stretch or take a biological break, and we will be back in just a few minutes. Thank you again, Dr. Spector.
Thank you again, Dr. Spector. We have also received a lot of positive feedback already, so thank you again for your presentation.